Come back. In this video I will discuss a very important topic, gout. So gout is an inflammatory arthritis. It causes inflammation in the joints and it is caused by deposition of monosodium urate crystals inside the joints, and it is due to hyperuricemia, that is uric acid levels in the blood are more than 6.8 milligrams per deciliter, leading to deposition in the joints. So clinical presentation, how patients present to us. There may be acute monoarthritis, mostly MTP joint of the big toe is affected initially. MTP joint of big toe. So it has sudden severe pain. There may be swelling and redness and it is tender. Classically affects first metatarsophalangeal MTP joint, also known as Podagra. Pain peaks within 6 to 12 hours of onset and mostly it may be at night time or maybe in the early morning. On examination, joint is warm because of inflammation, shiny, and on palpation it is extremely tender. Here you can see in image tophi on the extensor surface of the hand. These are tophi. Tophi are actually deposition of the urate, and against this there is foreign body reaction leading to formation of these tophi. Triggers. Alcohol binge leads to increase in the pain of gout. Red meat, trauma, stress, dehydration, starvation, and diuretics, especially thiazides and loop diuretics, lead to trigger of acute attack. Tophi, as I have shown you, are chalky nodules in the chronic gout, maybe on ear helix, in the tendons, on the fingers, as I have shown you here on the fingers. The patient may present as polyarticular in later chronic disease. Diagnosis. The diagnosis is made by synovial fluid aspiration. It is the gold standard for diagnosis. Gold standard for diagnosis is synovial fluid aspiration. On microscopy, you will see negatively birefringent needle-shaped urate crystals under polarized light microscopy. So polarized light microscopy shows negatively birefringent needle-shaped urate crystals. While in case of pseudo gout, you have positively birefringent rhomboid urate calcium pyrophosphate crystals. So in this way you can differentiate, because in gout there are negatively birefringent needle shaped urate crystals seen under polarized light microscopy. This is gold standard. Other investigations include serum uric acid more than 7 milligrams per deciliter, and it may be normal during any acute attack. So it is not that much reliable, but this is the gold standard, synovial fluid aspiration. Also, the cell count in case of cell count on synovial fluid aspiration is more than 20,000 per mcl, but less than 1 lakh per mcl in case of this inflammatory. ESR and CRP both are elevated and are inflammatory markers. On X-ray, in later cases when there is chronic gout, there are punched out erosions of the bones. These look like rat bite lesions, as rat has taken out your bone. Differential to exclude. Septic arthritis is a main differential because in case of septic arthritis, your joint is also warm, tender, red, and swollen. So you have to rule out this condition. It can be ruled out by synovial fluid aspiration and culture. Pseudo gout, as I have told you, in case of pseudo gout there are calcium pyrophosphate deposition leading to positively birefringent rhomboid crystals on polarized light microscopy. So these are positively birefringent, while in case of gout these are negatively birefringent. And also in case of gout these are not rhomboid but these are needle like. Acute attack management. First one is you have to relieve the patient's pain. For this purpose, you can use NSAIDs as first line. For example, naproxen 500 mg BD for 5 to 10 days. But if NSAIDs are contraindicated, like if patient is a cardiac patient, then you should go for colchicine. Colchicine is given within 24 hours and it works best within 24 hours. It is either given as 1.2 milligram stat dose and then 0.6 milligram BD until patient is asymptomatic. If the patient has kidney functions deranged or liver functions deranged, then colchicine cannot be used. Then you should go for oral or intra-articular steroids like Repicot can be given orally. Repicot is prednisolone. It can be given orally for 5 to 10 days. You should avoid allopurinol because it precipitates the acute attack, because rapid lowering of urate can lead to precipitation of acute attack. Long-term management. Long-term management is required when there are recurrent attacks or when there is tophaceous gout or when it causes urate nephropathy. So these are the indications when you have to start the urate lowering therapy. First one is recurrent attack, second one is tophi formation, and third one is urate nephropathy. You should start after acute attack resolves. Allopurinol can be used as first line urate lowering therapy. It is given as 100 mg per day orally and can increase the dose up to 800 mg per day. This is the maximum dose of allopurinol. You can also start Febuxostat, especially if there is kidney impairment. Febuxostat is given as 40 mg per day and can increase the dose up to 120 mg per day. Probenecid is a uricosuric agent. It can be added to allopurinol or Febuxostat, but it leads to increased formation of urate stones in the kidneys. So you should avoid this when there is risk of increased formation of stones, kidney stones. Colchicine should be added because it provides prophylaxis for acute attacks. So colchicine is given as 0.6 mg OD so that you can avoid precipitation of the acute attacks. So it is given as prophylactic agent. So this is all about gout.